So, neuromonitoring plays an important role in the safety of posterior lumbar decompression and fusion. Just first, thanks to Rock and Zori for inviting me. It's always fun to be part of these things. And I think it's a really interesting topic without consensus. These are my disclosures, not really relevant to the topic at hand. So when we talk about neuromonitoring and lumbar spine surgery, we're really kind of talking about EMG monitoring and SSEPs. And when we talk about EMG monitoring, there's two kinds of EMG monitoring. There's a spontaneous EMG monitoring, which is really meant to monitor for excessive manipulation of the nerve roots, kind of pulling or traction, compression, whatever. And there's no direct electrical stimulation of that nerve root. And we're essentially waiting for neuromonitoring to kind of say something if they see EMG activity as you're doing our procedure. And you contrast this to the triggered EMG monitoring, which is also known as testing screws. Traditionally, this is done with testing the nerve root at 2 milliamps with the probe, and then you test a screw at increasing milliamps. And in general, if it's 5 to 8 milliamps from your control, that's suggestive of a breach. Whereas if you're greater than 15 milliamps, particularly above your control, that is there's a 98% likelihood that there's no breach there. So this isn't foolproof. I mean, it seems like it would be foolproof because it's pretty scientific, but there can be false negatives. And the reasons for false negatives could be if there's parallax on board. Anesthesia can't have any parallax on board. Proper EMG probe placement on the screw. A lot of our screws are polyaxial, so if you place it on the tulip, it's not really directly on the screw, which may be touching the nerves. We want to make sure that that probe is on the screw itself and not just the tulip. And we also want to make sure there's clearance of other tissue or fluid which may affect the circuit. And finally, if the nerve root is injured, well, you may not get that EMG activity even if you're directly on the nerve root. This kind of highlights the importance of getting a control signal at 2 milliamps on the nerve root, which if you have a decompression ought to be easy enough to do, but sometimes isn't always feasible, for example, in percutaneous screw placement. And in the course of placing pedicle screws safely, there's a lot of different techniques that we have, and neuromonitoring is just one of them. We all know we can just use anatomic landmarks. I'm sure most of us in our open cases palpate with a ball tip probe to feel for a breach inferiorly or medially. We can actually do a laminotomy and feel the pedicle on the outside, the inferior and medial border to ensure, with a Woodson elevator, to make sure there's no breach. We can also use biplanar stem fluoroscopy, or we can use advanced intraoperative imaging, or even robotics and navigation. And of course, neuromonitoring triggered EMG testing is just one modality to check the safety over pedicle screws. So what does the literature say? To summarize, it's really all over the place. You'll find studies supporting this use and not supporting this use. Early on, this is a study by Welch and others, over 164 pedicle screws, and they concluded that this technique of using EMG monitoring or and SSEP monitoring may be useful to surgeons early in their implant experience or during particularly technically difficult operations. This is a study out of European Spine Journal, where they looked at lumbosacral surgery and multimodal intraoperative monitoring for 409 patients and 409 surgeries and 409 patients. And they've reported a 90% sensitivity for nerve root injury and a 99.7% specificity. And it's worth noting that this is with spontaneous EMG monitoring. No triggered EMG was done in the study. This is a study by Gunnarsson and Failings, real-time continuous intraoperative electromyographic and somatosensory evoked potential recordings in spinal surgery. Correlation and clinical and electrophysiological findings in a prospective consecutive series of 213 cases. And what they found in this study is that the EMG was actually 100% sensitive for new neurological deficit, but it was only 23.4% specific. Conversely, SSEPs were 28.6% sensitive, but 94.7% specificity. So by using both, you can kind of get the best of both worlds. And they concluded that neuromonitoring is both helpful in predicting and possibly preventing neurological injury. On the flip side of things, this is a study out of Los Angeles. Zori, who's the co-author on the study. The utility of intraoperative neuromonitoring for lumbar pedicle screws is questionable. A review of 9,957 cases. And what they found here is that the risk of neurological conditions following a post-lateral fusion in the absence of deformity is low. And the routine use of neuromonitoring may not decrease its use. So in those that had monitoring, they found that the risk was 1.36%. Those that didn't have monitoring, the risk of injury is 1.34%. So not a big difference. As you can imagine, with that many cases, we're probably looking at some kind of database study, and this is a Pearl diver study, which of course is reliant upon codes. Whenever you use codes, you have to be mindful of what those codes are looking at. In this case, when you code for EMG monitoring or when you bill for EMG monitoring, there's no differentiation between spontaneous versus triggered EMG monitoring. So we don't know exactly what kind of monitoring was used. There's another study by Osterman and others using the NIS database. Now, their discussion in the results section is kind of scant, but they concluded that the neuromonitoring use did not impact the likelihood of developing a neurological condition, and they felt there was no meaningful benefit to its application. They felt that most people use it largely for medical, or they imply that most people use it for medical legal implications. And finally, this is a study by out of Baltimore, Tim Witham's group, looking at 2,450 screws, and they use postoperative CT scans to assess for a breach. And they use a pretty specific criteria. There's 5.0 milliamps and higher. And when they tested the screw at 5.0 milliamps, they found that the specificity, oddly enough, was 99.9% of a breach detection. And the sensitivity was low, only 43.4%. But if they increased their milliamps threshold, that sensitivity number went up to 69.6% and so forth. What they concluded was that any screw showing positive stimulation below 5 milliamps warrants immediate intraoperative investigation. Interestingly about this study, they looked at postoperative CT scan breaches as their measure of outcome, and not so much clinical symptoms. And sure, while the breach certainly increased their likelihood of clinical symptoms, they are not necessarily synonymous. So in regard to the literature, there's really no consensus. I'm sure Don will present other literature on both sides of the argument, both sides of the discussion as well. There are studies supporting its use. There are studies not supporting its use. But most studies will agree that this can play a role. Clearly, there is some utility to using neural monitoring in lumbar spine surgery, particularly revision surgery where the anatomy might be obfuscated. Deformity, if there's some kind of more than usual nerve root manipulation or nerve movement. MIS surgery, where maybe you don't have all the other tools at hand, maybe you're not doing a laminotomy and you can't check your pedicle screw safe placement with the usual techniques. And I put an asterisk by this because I'm going to go into this a little more detail later on in this presentation. So basically, neuromonitoring lumbar spine surgery really is a question about safety. Does it enhance the safety of what we do? So I want to ask the question, do we absolutely, unequivocally, 100% need neuromonitoring during lumbar surgery? And I would say that the answer is no, because can we achieve the goals of lumbar spine surgery without neuromonitoring? And I would say the answer is yes. We do have techniques to be able to ensure safety of what we do, and we don't absolutely 100% need neuromonitoring during lumbar spine surgery. But can neuromonitoring play a role in enhancing the safety of spine surgery? And to this question, I would say yes. Yes, neuromonitoring is not perfect, and there's definitely, we need to know how to interpret the signals and be aware of false negatives and false positives. But on the whole, it does have a role in enhancing safety in spine surgery. And when you think about those three questions, do we absolutely need it? Can we achieve the goals of surgery without it? But does it enhance safety? Think about those questions and those answers. And think about, if you take a step back and look at lumbar spine surgery, think about all the things, all the tools we use, all the techniques we use, and what else fits in that category. For example, robotic and navigation guidance in OR. Is this something that we absolutely need to perform lumbar fusion? No, we can certainly do it without it, and we have. But can we achieve the goals of surgery without it? Absolutely. But does it enhance safety? And for some surgeons, the answer might be yes, depending on what their comfort level and familiarity with instrumentation is. What about CM fluoroscopy? Do we absolutely need this? Well, no. We used to use portable X-rays to visualize the spine radiographically. So we know that we can achieve the goals of surgery without it. Does it enhance safety? I would say yes, it does. It definitely makes it faster than waiting for a portable X-ray. And if you can decrease overtime, that certainly increases the safety of the surgery. But if you take that one step further, do we even need portable X-ray? There was a time when we did these surgeries without portable X-ray. You make a larger incision, you feel the sacrum, you count from the sacrum up to the whatever levels you want to be at. You do your laminectomy, you put in your pedicle screws using anatomic landmarks. So theoretically, we don't even need portable X-ray to do our surgeries. We can achieve our goals of surgery without portable X-ray. But no doubt about it, just some kind of radiographic visualization does enhance patient safety. Operative microscope. We know we can do these surgeries without an operative microscope. We can use loops to headlights. That's the way I was trained. But I think you can see a lot more. So I think it does enhance safety, and it does. We can achieve the goals of surgery without the microscope, but certainly it enhances safety in my mind. It also helps my neck feel better, so I don't have to wear all that stuff in my head. And if you think about the specialized tools, everyone does their surgery a little bit differently. Some people use a motorized burr, some people use Kerrisons, some people use a Masonics bone scalpel or Aquamantis. And these are all things that we use because in our own hands, in our own preferences, we believe they enhance the safety of the surgery that we're about to do. But we don't absolutely need every single one of these things, and we can certainly achieve our goal of surgery without a lot of the tools that we use. This is a case, well, this is not the exact case, but it's an example of a case. So in my first year of practice, I saw a patient with a far lateral disc herniation. And we all know that after non-operative treatment fails, the surgical treatment fails will be a Wiltsy type approach for a microdiscectomy, where you can see that we go lateral to the facet as opposed to medial to the facet. I'm not going to lie to you, my first year of practice, I was a little bit nervous about this case because honestly, I hadn't seen too many of them. And though I knew what to do, I just wasn't familiar with the anatomy. So upon exposure, and this is lateral to orient you. This is the L4 transverse process. This is the L5 transverse process. And there's facet. Now you can see the nerve here, but before we get down to this point, after you take off the intertransverse membrane, it became a little bit difficult for me because I wasn't 100% sure where that nerve root was. And if I start dissecting, I got some bleeding, and then, yeah, sure, I use my bipolar cautery to address the bleeding, but I'm a little bit nervous about using bipolar cautery when I'm not 100% sure where the nerve root was. So maybe I use my flow seal or SurgiFlow, then I use a 1x1 padding, kind of pack it in there. But am I jamming my bayonet and padding right onto the nerve root? Because I don't know where it is. I'm not 100% sure. So in this case, my first year of practice, I use EMG monitoring. And what I did is I took that EMG probe and I set it at 2 milliamps, and I kind of hunted for the nerve root. And I found out where I would get EMG activity. So I knew that over here, I wasn't getting any EMG activity. Around this area, I started getting EMG activity, and back here, I wouldn't. So I had a rough idea where the nerve was. And with this orientation, this allowed me to dissect a little bit more aggressively with my bipolar cautery. You can see I kind of, fried the heck out of the tissue lateral to the nerve root and medial to the nerve root as well. And this allowed me to localize the nerve root and find things, and essentially allowed me to be more safe. Is this an extraordinary case? No, this is not revision. This is not deformity. This is a pretty ordinary case. But in my first year of practice, I wasn't sure of my anatomy. I wasn't sure how much I could really pull on that nerve root. And in this case, the EMG monitoring did help me significantly. So when we think about neuromonitoring, we know that it can play a role in revision cases, deformity cases, and MIS, but I would submit and I would contend that it also plays a role in other cases. Spine surgery is not easy. And at some point, once we get past all the studies and all the data, at some point, medicine and surgery becomes an art. There's a certain comfort level and a familiarity level that we don't necessarily quantify on paper. There's no book that tells you how much tension a nerve root can tolerate. There's no YouTube video that can teach me that. The only way you can learn is through experience and repetition, and feeling that tactile feedback again and again. Now, if we use other modalities such as neuromonitoring to help us kind of get to that point, I think that's completely fair. I think every surgeon has a different familiarity level, experience level, and comfort level at different kinds of surgery. And the use of neuromonitoring should not be disallowed. And if people want to use it, I think that's absolutely fair game. If you think about this debate, in the United States, neuromonitoring for lumbar spine surgery, payers are starting not to authorize for neuromonitoring use. So there is that side of the how this argument or how this debate is manifesting in real life. But on the flip side, if you don't use neuromonitoring and you have a patient wake up with a neuro deficit, those patients will sue. And I know there's examples of this from just anecdotal feedback from colleagues. So these are real life issues in terms of there's both sides of the spectrum. My conclusion is that neuromonitoring for lumbar spine surgery is one tool of many to optimize the safety. And that tool should be decided at the discretion of the treating surgeon. It should not be a requirement, meaning if someone chooses not to use it, I think that's fine if they're comfortable with that. But it should always be an option. And depending on where you are in your relative comfort level or familiarity level, it should be at the discretion of the surgeon, whether it's revision, MIS, deformity, or just safety. And if that's a question of me, I feel safer with this modality on board, then by all means, I should be allowed to use it. And I think that's at the discretion of the surgeon. So in conclusion, neuromonitoring plays an important role in the safety of posterior lumbar decompression and fusion. Thank you.